Good evening, everyone. I am Dr. Smitha Saldanha from Kidwai Memorial Institute of Oncology and HCG Hospital, Bangalore. I am here to speak on two papers presented at the ESMO Congress, HER2 on HER2 positive breast cancer. So coming to the first paper, it's on the 9 weeks versus 1 year adjuvant trastuzumab, the long-term outcomes of the short duration HER2 randomized trial. So coming to the background and the rationale for the study. So in 2005, we had the first phase 3 trial, the HERA trial, which showed the superiority of the duration of 1 year trastuzumab to adjuvant chemotherapy in early breast cancer HER2 positive. And based on this data, the trastuzumab received accelerated approval as adjuvant therapy for HER2 positive early breast cancer. And these are the various dates. As per the FDA was the last to give the approval in 2006 November. And based on this, most of us recommend a treatment of 1 year duration of trastuzumab administration. So there was a similar benefit seen when they gave for 9 weeks duration of trastuzumab compared to the 1 year, but it was a small number of patients in the FINHER study. So the need for the study was we required a larger number of data with more number of people in a randomized study where both the high risk patients were taken and looked for the benefit of short duration versus long duration trastuzumab. So this addressed this particular gap which was seen in the earlier trial design. So it was an investigator-driven non-inferiority trial, and they had set up the non-inferiority hazard ratio at less than 1.29. The power of the study was 0.80, and the initial sample size which was planned was 2,500 patients, and they had planned to start the study from February 2011. So it was funded by the Italian Drug Agency, and it was sponsored by the University of Modena Reggio and the University of Padova, and basically it was done in 82 investigational sites in Italy. The recruitment period was from 2007 to 2013. So in this short HER study design, they basically took only HER2 positive patients, node positive or high risk node negative patients, and they were randomized to either the short duration or the long duration HER2 therapy. So as the long duration shows over here, they usually followed the anthracycline cyclophosphamide regimen followed by either the taxanes with the HER2 anti-HER2 therapy for a duration of 1 year. And most of the patients above 65 years received docetaxel 80 mg per meter squared. And if it was a short duration, initially they received docetaxel with the anti-HER2 therapy followed by the anthracycline and cyclophosphamide dosing. And as the standard regimens dosing, it was the trastuzumab was given. So if you look at the patient characteristics, there were 627 patients in each of the long and the short arm, a total of 1,250. So from the initial predefined 2,500, they had come down by 50%. And most of the patients, almost 63 to 64%, were in the postmenopausal patients. Almost 75% to 80% of the patients were stage 1 or stage 2 breast cancer, and almost 50% were node negative, 30% node positive, that is N1, 1 to 3 lymph nodes. And if you look at the hormone receptor status, almost 67 to 68% were hormone receptor positive. Now what was the analysis? So when you looked at the short in the primary DFS analysis, the Kaplan-Meier disease-free survival estimates shows the overlapping of both the curves of the arm A and the arm B, that is the long HER2 therapy with the short HER2 therapy. And this was at a duration of almost 96 months. So it shows that probably the short is not inferior to long course of trastuzumab, and the hazard ratio is 0.78 over here. So it matched the predefined hazard ratio. And if you look at the cardiac adverse events, the time to the first cardiac adverse event that's more than grade 2 was definitely higher with the long course anti-HER2 therapy compared to the short course. The hazard ratio was 0.32 with a p-value of less than 0.001. So almost 13% of the patients developed cardiac events in the long course versus only around 4.3% in the short course of anti-HER2 therapy. So the update that they presented at the ESMO 2021 was a follow-up of 8.7 years with 237 DFS events and 109 deaths. So they presented the long-term outcomes by the risk categories, the low risk of where the T size is less than 2 centimeters and node negative, the high risk where it is any T with more than 4 lymph nodes positive, and the intermediate where it was with node positive with less than 2 centimeters or node negative with more than 2 centimeters. So when you looked at the long-term DFS curve, again the Kaplan-Meier disease-free survival estimates almost shows overlapping of both the short and the long. 121 events in the short and 116 events in the long with hazard ratio of 1.09. And this was at almost 120 months. So if you look over here also, it's almost at 108 months, 0.80 hazard ratio with 0.783. So if you looked at the long-term overall survival data, again there is overlapping of both the short course and the long course HER2 therapy with the hazard ratio of 1.18. And when you're looking at the risk categories, depending on the risk categories, the long-term DFS and OS, if you look at the high risk as depicted by the dark blue and the navy blue and the light blue, intermediate risk. So for the high risk, definitely I think, yeah, the long course is better. But for the low risk and the intermediate, there's almost an overlap of both the long or the short course trastuzumab. And if you look at the hazard ratio here, for the low risk it's 0.91, for the intermediate 0.88. For the high risk, you see the wide separation of the curves with the hazard ratio of 2.06. So in conclusion, at a median follow-up of 8.7 years, the 5-year DFS for the long course was 87.9% versus short 85.8% with a hazard ratio of 1.09. It matched the confidence interval, it matches the thing. And the 5-year overall survival in the long course, it was 95.1%, in the short 95.1% with a hazard ratio of 1.18. So patients classified at low or intermediate risk on the basis of T size and nodal status represent 84 to 85% of the short HER2 population. In this patient population, long-term DFS and OS are superimposable in the 2 treatment arms. So although 1 year is a standard of trastuzumab remains a standard, de-escalated treatments are a reasonable option for a large population of our real-world HER2 positive early breast cancer patients. And we can try this in our setting also. So coming to the next paper, the individual patient data of the meta-analysis of the 5 non-inferiority randomized controlled trials. So where they looked at the reduced duration single agent adjuvant trastuzumab in the treatment of HER2 positive early breast cancer. So basically it tries to address whether giving reduced trastuzumab for 9 weeks to 3 months versus 12 months, is it helpful? So basically it took a meta-analysis of 7 trials in the early breast cancer patients. So if you look at the non-inferiority randomized controlled trials for trastuzumab duration, you have the Persephone where 12 months versus 6 months, almost 4,000 patients. The FAR-A trial, 12 months versus 6 months in 3,380 patients. The HORG trial, 12 months versus 6 months in almost 493 patients, a total of 8,000 patients. And then you have the SOLD where it is 12 months versus 9 weeks, almost in 2,000 patients, and the short third trial 12 months versus 9 weeks, again in a 1,200 odd patients, or roughly around 3,500 patients. The total number of patients were around 11,389 patients. So it was basically on the non-inferiority design. So the the analysis what they planned was, they looked at the non-inferiority margin of 2.5 2% which was pre-specified, and they looked at the 5-year invasive disease-free survival rates predicted from the random and fixed effects modeling. And the non-inferiority hazard ratio limits were subsequently determined to compare against the upper credibility intervals of the calculated hazard ratio limits. So they looked at the absolute risk of 2% margin, should not have been lesser than 2%, and the relative risk was it converted the margin to hazard ratio limit, which only depended on the baseline risk. So as we know, in non-inferiority trials, it's very difficult to get a superiority. It's only trying to tell you it is not inferior. So let's look at what the trial showed results. So basically from the 4 trials and the published data has been used from FARE. So for the intent to treat analysis of the primary outcome of the IDFS, the non-inferiority limits hazard ratio of absolute 2% margins were calculated. So 1.19 for all 5 trials comparing 12-month versus less, and 1.20 for 3 trials comparing 12-month versus 6 months, and 1.25 for 2 trials comparing 12-month versus 9 weeks. So in the results, when they applied the random effects model. So they looked at the 5-year invasive disease-free survival rates. It was 88.46% versus 86.87%. So if you look over here, the forest plot, almost the 6 months, both the Persephone and the FARE prefers the comes into the non-inferiority limit, whereas your HORG and the SOLD does not fit into the non-inferiority limit. The shorter also just meets the non-inferiority limit. And if you look at the 12-month versus 6 months, the 3 trials combined, when they looked at the fixed effects model, again both the FARE, the Persephone fitted into the non-inferiority limit except the HORG, which was a little short beyond the non-inferiority limit of 1.20. And when you looked at the 12-month versus 9 weeks, if you look here, the shorter fits into the non-inferiority limit of 1.25, whereas the SOLD trial did not fit into the non-inferiority limit. So in conclusion, the non-inferiority of 6 months trastuzumab was established by this meta-analysis compared with the 12 months. The non-inferiority of 9 weeks versus 12 months has not been confirmed by this meta-analysis. So how will it affect our practice? So we all know that giving for 12 months is definitely beneficial. So we can de-escalate to give it for 6 months, but not yet for de-escalating for 9 weeks. So therefore, we need to still, depending on this practice, continue providing 12 months of trastuzumab or at least 6 months of trastuzumab and not for 9 weeks of trastuzumab. With this, I will end my talk. Thank you.